I wanted to thank my dear colleague from Serbia, Mladen, for meeting me first in China a few months ago and extending the invitation to come to a beautiful city. You're really beautiful people and you have a beautiful country, and so far I've witnessed a lot of wonderful things during this visit. I wanted to say to the Minister of Health about the similarities between Los Angeles and Pancevo. There are many similarities. Your roads are blocked by tractors, and our roads and highways are blocked by a million cars every day. So, now, having said that, I was assigned the task of an uncommon topic, rectourethral fistula. And like everything else in life, there's usually two perspectives on things. For rectourethral fistula, there's perspective of the urologist, and there's also the perspective of the colorectal surgeon. So today, I would like to share with you, my perspective as a colorectal surgeon of how to approach this uncommon condition. Just briefly, looking why this problem occurred, this is a cross-sectional picture from a cadaveric studies, and as you see, the prostate anteriorly in this area with the urethra, and right behind it is the rectum. And anything potentially that affect the prostate or the rectum could lead to a communication between the two organs. That space in most men is just a few millimeters, the separation between the two organs. And, let me see. And so basically what we're going to be talking today about is when you do form a communication between the two organs. And most of these communication, when they occur, they're going to be in the lower portion of the rectum, and they usually will go to the bladder neck or this portion of the urethra. Other type of communication that can form between the rectum and the urinary system could form at the level of the bladder, but these tend to be related to the sigmoid colon most of the time from diverticular disease in Western country. So the focus of the talk today is specifically for rectourethral fistula. This is a very complex problem, and it's a very difficult problem to treat. Most of the patients who we see with rectourethral fistula, usually it's related to an iatrogenic injury. Iatrogenic meaning they develop the problem secondary to a treatment most of the time for prostate cancer, but other etiology cause that. It carries significant morbidity to the patient, and it could be very frustrating for the surgeon who hasn't seen enough of these and doesn't know how to manage the patient. It usually requires numerous intervention. When I see a patient in my office, for instance, after radical prostatectomy for prostate cancer, these patients come in with the expectation that they're going to have one procedure, removal of the prostate, and suddenly 8 or 9 months later, in the office of a colorectal surgeon, after the placement of suprapubic catheter to drain the bladder and a colostomy. So suddenly the patient goes from one operation to 3 operations. Now when you see them in the office, tell them, well, at least they're going to require one more operation to fix the problem. And if the problem is successfully tackled, then they're going to need a 5th operation, which is closure of the colostomy. So because of these numerous interventions, usually it's very complex, and the patient more often than not are really upset at what happened to them. And finally, even when you successfully repair the fistula, there's question about the long-term function, both of the anorectal area in terms of continence, as well as the urinary function in terms of urinary leakage and incontinence. And in some patients, depending on the magnitude of the injury, they may develop permanent stricturing of the urethra. The etiology, they're basically 2 broad categories. Congenital, we have children who are born with the condition, but today we're going to be specifically talking about the acquired type of rectourethral fistula. And by far, the 2 most common conditions that lead to that is iatrogenic or trauma. Trauma could be penetrating, wounds, but also could be trauma from us as surgeons doing procedures or operation in the area that lead to the fistula. In the West, we also see a lot of radiation-induced rectourethral fistula. Less commonly would be rectourethral fistula related to inflammatory bowel disease, such as Crohn's disease. and less commonly would be atypical infections such as tuberculosis. And finally, malignant rectourethral fistula can also present. When you look in terms of how common this problem is, I'm going to share with you data from few series around the world that looked at this. This particular series, published in 1999 from the Mayo Clinic, reported 16 men, and as you see, 15 had prostate cancer, only 1 had bladder cancer. And when you look in terms of what caused the rectourethral fistula, about half of these patients was following radical prostatectomy. The rest of the patient were related to combination to either operation with external beam radiation or brachytherapy, local implantation of radioactive seed. And 1 patient developed it following cystectomy and dilation of a stricture. When you look specifically at brachytherapy, this is one of the treatment for prostate cancer where the radiation oncologist implants radioactive seed in the prostate bed. This particular series from Harvard University, from Brigham and Women, found a 1% incidence. They had 7 cases in 700 patients they treated. There have been other series, however, that have reported up to 4% incidence after brachytherapy. It's also interesting to note that most of these patients would not develop the problem right away. And that's very important when you're counseling the patient, because when you tell them this is related to the radioactive seed implant, and they in your office 2 years after that treatment, they say, but doctor, you know, I had my treatment 2 years ago. Why now the fistula? But this is the process of gradual necrosis of the prostate. And most patients you're going to see 2 years or more after the initial treatment. There are various risk factors when people have done brachytherapy that lead to that. Some people feel, you know, the placement of the seed, especially in the posterior aspect of the prostate, the dosage that is being used, and also the experience of the radiation oncologist as they're doing the procedure. At my institution, I treat all the rectourethral fistula for our region in Southern California. We cover a population of slightly over 3.4 million patients. And in the last 8 years, I've had 29 patients that would refer to me. And this gives you an idea of the current etiologies. Over half of these patients, again, were related to surgical procedure. 15 were related to laparoscopic prostatectomy, 1 robotic prostatectomy, 5 open prostatectomy, and the rest have been either radiotherapy plus or minus cryotherapy. That's a treatment modality where you freeze the prostate to kill the cancer. We had 1 patient with Crohn's disease, and 1 patient came in after trauma. How do we classify rectourethral fistula? As most of you know, when we look at fistula and ano, we have classifications that kind of guide the treatment as well as prognosis. For rectourethral fistula, because it's not a common problem, they have not been a standard classification. But most of us who deal with it, we tend to think of it as simple versus complex. If it's related to a traumatic injury or a procedure, it tends to be a simple one. Versus fistulas that present after radiotherapy or cryotherapy, or those that come in with congenital problem, they tend to be more complex. We also, anytime we're assessing a patient with rectourethral fistula, we need to investigate to see if there's a stricture in the urethra associated with it. In terms of location, as I alluded to in an earlier slide, most of these are in very low rectum, and all the one that I've seen, usually you can feel with a finger, most of the time within 5-6 centimeters from the dentate line. The size, however, of the fistula can really vary. If you have a minor injury following radical prostatectomy, the hole may be just a few millimeters. Those that have had total destruction of the prostate from brachytherapy, you could stick 2 or 3 fingers easily from the anus into the fistula. And sometimes the effect of the radiation have been so devastating to where you could feel all the way anteriorly the pubic bone, which become bare from the destruction in the tissue. How do patients present? They have various presentation. The patient who've had, let's say, radical prostatectomy in the immediate postoperative period, they may present with a pelvic abscess or a severe necrotizing infection, which is rarely seen. But most will present with chronic symptoms, and the symptoms that most often patient complain of would be passage of urine out of the rectum. When the patient is sitting or standing, they note that fluids start coming out of the rectum. A patient could also have either gas or stool particle in the urine when they urinate. They can also have recurrent urinary tract infection. Pain is noted in about 50% of the patient, and it tends to occur more in patients who've had radiotherapy. And interesting enough, after you treat these patients, a lot of time the pain will resolve. Rectal bleeding can occur. There have been few reports in literature of massive and fatal bleeding from the anus related to the fistula and erosion into a vessel. Now, if you see a patient in the office, what are the things that you need to do to evaluate the patient? Obviously, the history, what type of surgeries they've had, and not only on the prostate, but also prior surgeries on the anal area or the pelvic area. History of radiation therapy, how much radiation therapy. More importantly, for those who've had prostate cancer, what is the current status of the prostate cancer? Do they still have active disease or not? Because that will guide what type of intervention you will do. Endoscopies, you can look inside on the rectal side with either colonoscopy or flexible sigmoidoscopy, and you could do cystoscopy, looking through the urethra into the bladder to take a look at the location of the fistula, and also document in relationship to the urethral opening, draining the kidneys on both sides, how far up that fistula is, because that does have some treatment implication. In terms of imaging, we can do cystogram, where we put a dye into the bladder to fill it up. We could do a gastrograph enema, where we put dye through the rectal side to try to delineate the anatomy of the fistula. And usually when I get called by a colleague, especially in the acute setting after an operation, I always recommend to get a CT scan to make sure there's not a pelvic abscess that need to be drained percutaneously. So CT scan usually is more useful in the acute setting, but not as much in the chronic setting of a patient who've had symptoms for a while. And these are a few illustrations, samples of patients who've had rectourethral fistulas. I'm going to show a few just to illustrate some of the point I discussed. This is a patient who've had a brachytherapy, and if you look here, I don't know how well it projects, but you see these tiny implants here. There's a tube in the patient penis, and you're about to fill in the urethra. You start seeing the filling of where the prostate used to be. This would have been just like a tubular structure, but the entire bed of the prostate have been destroyed by the radiotherapy. And as you continue to inject contrast, you see the rectum now is filling up with contrast. This patient, if after a laparoscopic radical prostatectomy, and here a cystogram is being done, the bladder starts filling up, and you start seeing extravasation of contrast going into the rectal side. This particular patient came in, had a treatment previously, but still had an active malignancy, and you could see the tubes inside the patient anorectal area, and there's a balloon here. And as you inject the contrast into the rectal side, you see contrast coming around the tube and kind of going in and filling the bladder area. On this particular CAT scan, this was an interesting story. It was the only traumatic rectourethral fistula I've seen. This patient had had a transurethral resection of the prostate for enlarged prostate, and they really did a lot of extensive resection in the posterior aspect of the prostate to where there was just one layer of tissue. And then subsequently, somebody put a Foley catheter into the patient, and if you look at these slides, this first CT scans, you see the urethral catheter here going through the penis, and as you go down, you see this is the prostate, and you see this catheter in between the prostate and the rectal side. And as you go further down, you see the balloon of the urethral catheter sitting in the patient's rectum. So basically, this was prior surgery, too thin of a tissue, a traumatic insertion of urethral catheter, and suddenly the patient has a rectourethral fistula. And here, when you do a gastrographin or a cystogram, contrast-enhanced cystogram, you see how the contrast after filling the bladder goes into the rectal side. So this is an example of a traumatic rectourethral fistula.